Hello, everyone. Good evening for those of you in Ann Arbor and other points in the Eastern time zone, or good morning or good afternoon for folks who are in other parts of the world. I'm Jonathan Massey, Dean here at the Taubman College of Architecture and Urban Planning at the University of Michigan. And I'm glad to welcome you this evening to a Taubman College alumni panel discussion on the subject, as you well know, of the future of healthcare design, something that is very much on the minds of practitioners in architecture and urban planning and the health sciences and medicine, but also, of course, on the minds of many of us as we interact in new ways with healthcare and with questions about how the built environment contributes to our well-being, to our safety, to the goals of public health, and the ways that architecture and the built environment can exacerbate our vulnerability to disease or debilitate us or inhibit our well-being. And we have a chance tonight to hear from three leading practitioners who have been for many years and are shaping this conversation through their professional activity and their design research and their expertise. So we're going to have a conversation this evening among three Taubman College alumni. We're going to talk with Robin Gunther, FAIA, who serves as principal at Perkins & Will, and who is also senior advisor to Healthcare Without Harm, a global nonprofit. Robin is based in New York City. She works at the intersection of healthcare architecture, health, and sustainable policy. She is a Robert Wood Johnson Foundation Culture of Health leader and the author of Sustainable Healthcare Architecture. She was named in 2010 and 2011 the #1 most influential designer in healthcare by Healthcare Design magazine, and she earned her Master of Architecture degree from Taubman College. Welcome, Robin. We are also going to hear from and meet Parini Mehta, Associate Principal at Co-Architects, who has 15 years of experience managing large healthcare design projects throughout California, including projects at Scripps Health, Stanford University Medical Center, LAC USC Medical Center, Cedars-Sinai, and UC San Diego, as well as UCLA Health. She's known for her strong work ethic, thoroughness, and thoughtfulness in crafting creative options and solutions. Parini holds a Master of Architecture from SCI-Arc, the Southern California Institute of Architecture, as well as a Bachelor of Science in Architecture from Taubman College. And our third alumnus joining us this evening is Mike Puxta, who is the co-leader of Canon Design's healthcare practice. With expertise across a broad range of topics, Mike offers critical insight into the many social, economic, and human variables that shape healthcare environments. Mike's been published in periodicals such as Fast Company, Becker's Hospital Review, Quartz, Stat, Herd, and Healthcare Design. Mike is based in St. Louis, and he holds both Bachelor and Master of Architecture degrees from Taubman College. Welcome, all three of you. Thanks for joining.
Thank you.
So, as we were discussing back in our virtual green room, I thought we could start. So for audience members, if you have not participated in these alumni conversations with us before, we're going to I'm going to lead off with some questions for our panelists, and then we welcome your comments, your questions, your responses through the comment feature on YouTube. And we will shift over the course of the conversation toward trying to address as many of those as possible. Though in my experience, one of the great things about our panelists is that they're going to bring in a lot of ideas of their own. And so we may not be able to address every topic. But we're going to start with an opening question for our three alums. And that's about the incredible range of the intersection between health and the built environment. So nearly every dimension of the world around us, from planning and design through construction and operation of buildings, nearly every dimension of that built environment affects our health. And so from one perspective, the intersection of design and health encompasses almost all of architecture and planning. It's ubiquitous. And at the same time, there's a tremendous amount of specialized expertise that goes into designing clinics, hospitals, healthcare facilities that have very demanding and precise requirements. Each of you leads a practice area at your firm that's dedicated to health. Maybe we could start by hearing from you how you approach health across that spectrum, from specialized facility design to a set of general or universal considerations. And Parini, I'm going to ask you to kick us off, and then we'll let it flow from there.
Sure. Okay. Well, thank you for having me. We know that healthcare facilities have played such an important part of our society, especially in the last 1 year. And so you cannot talk about the built environment anymore without talking about health and welfare of people, of our society. At Co-Architects, we always consider the well-being of our patient, but I think universally, we've also paid very special attention to the healthcare worker. There's been a spotlight on what the healthcare workers have been doing to combat the pandemic, and hospitals are dealing with shortages of staff, they're dealing with burnout, they're dealing with retention. And so for us, the built environment is not just for the patient and their families, but it's so important to design for and include the people that are spending day in and day out working 12-hour shifts in our spaces. So the important aspects of design: acoustics, lighting, daylight, color, ergonomics, communal spaces, respite spaces. Those are features that we as healthcare designers always look to provide, but more important, more than ever right now, it's no longer acceptable to provide a respite space in an exit stairway for a healthcare worker. We need to provide respite spaces for them within the places that we create.
That's beautiful. Mike?
Yeah, I'm intrigued. You brought up something about hospitals and health, and I think what we've been really trying to tease apart in our practice is really the fact that hospitals or healthcare does not equal health. Health is something that transcends healthcare, transcends a building. And I've just had the fortune of building out a practice for maybe 15 years now, where we've taken, I think, our design expertise, and we've been fantastic at architecture and engineering, doing things like that for a long time. But we've realized that to solve some of the greater problems of health, we actually need to think in a very interprofessional fashion. So I think, as we start to think about, can we as designers improve health, the teams that I love to surround myself with are social anthropologists and PhDs in public health and clinicians and people that really think broadly about health, not just hospitals and not just the built environment. And, in some ways, we have clients asking us to build bigger hospitals for them. And in the back of my mind, I'm thinking, we've failed as a society if we need to build bigger hospitals. We actually need to solve different kind of problems. I was at I'll give a little side story. The advisory board is a organization a lot of hospitals belong to. University of Michigan belongs to them. 3/4 of the hospitals in the country probably belong to them. Back when we could get together in person, their last big event, they bring hundreds of people together for a national event. They did something they've never done before. They had everyone get in groups of 5 people and form little teams. And they've never done this. This was always just a lecture. And this was a whole bunch of hospital administrators who aren't architects or designers for the most part in there. And they said, we're going to give you a really tough healthcare problem to solve. Solve poverty. And it was really intriguing to have a whole bunch of hospital leaders that are just driving healthcare to say, I need to solve poverty. But they gave us 15 minutes and the conversations were amazing. And I was so proud of that organization because they really realized that there are things that we really need to solve to create better health in society, and poverty is a huge piece of it.
Thank you. Robin.
So I'll just build on what both Mike and Parini have said and say that we too at Perkins & Will have realized that this is an interdisciplinary issue and that it transcends market sectors and professions. And and that the best solution, the architect is facilitator, right? Where really increasingly we're called upon to organize and kind of manage more complex teams that have that expertise that Mike mentioned, that really transcend the disciplines that we traditionally think or thought we'd be working with at the time that we were educated by you guys at Towman, right? On the role of the architect is really, transforming how buildings are designed and delivered. And I think that health is a really powerful catalyst for the built environment and for leveraging innovation in the built environment. That we've waited a long time for the emergence of research methodologies to measure the impact of some of these design interventions in the built environment. We've waited for the right equipment to measure, the right processes to put in place to really begin to link the interventions to the outcomes. And that's just in its infancy. But I think it's here to stay, and the evidence is going to keep compiling around, the contribution of the built environment to the degradation of health for both people and other life forms on the planet. And I think that as that continues, I think, to bring it back to healthcare for a minute, I think for a long time hospitals really believed that the business of saving lives was their contribution to the health conversation in society, right? And now they've been really being called on to really think about their own impacts to degradation and environmental issues. They're being called on to understand how they both improve health and the ways in which their processes and work does not improve health. And so, it's a fascinating area to work in for architects because it is coming to the front line of that reconsideration of what is health.
Robin, you have very eloquently linked the human-centered questions that we tend to focus on in thinking about healthcare design and designing for health to those larger ecosystems and your commitment to sustainability. And so I think you hinted at some of the convergences, some of the ways that sustainability is a way of promoting human well-being as well, human health. But could you talk a little bit more about where do you find divergences or tensions between those two priorities of yours? Or are there some particularly compelling intersections that you think are going to be very active in upcoming years?
Well, in the early days of sustainability, if you tracked how hospitals engaged in sustainable design, and since I wrote the books in 2008 and 2013, I spent a lot of time looking at who was engaging in this and who wasn't. And certainly in the beginning, you saw the most work being done really by community hospitals that were in parts of the country where environmental values were important. So, a lot of work around the Great Lakes. It felt like that's who was leading the charge. And who was absent from the table was, in a lot of ways, like the academic medical centers and the kind of places in the country that don't have those societal values as expressed. And so what's really been a huge difference in that equation has really been the science of linking health to these environmental issues. So, for example, it took the Journal of the American Medical Association, as well as the Lancet and now Health Affairs, to really start writing about the carbon footprint of healthcare and the relationship between burning fossil fuel and respiratory disease. to really wake up, I think, the academic community to say, okay, so we're at the front end of this medical game, but this is also part of this is our footprint. And we don't, what I think has been true about healthcare from the beginning is when the science connects the practices to human and environmental health impacts, the industry needs to change. Like, it is irrefutable. It connects it to mission, it pushes it in the door, and then it is just part of what they have to do. And it's in the lack of that explicit linkage that I think has caused people to see healthcare as maybe sitting back or lagging a little. But I think that's all changing now. And with the change in administration, it's likely to move even faster.
Mm-hmm. The one of our audience members, Rebecca Selter, is noting in the comments section that there's a farm at the St. Joseph Mercy Health System here in Ann Arbor that is addressing nutrition literacy in its community, as well as providing fresh food to the underserved, tackling some of those intersectional issues that you pointed to, Mike, in your introductory comment. Your comment, Robin, about academic medical centers makes me think about how at a big university like Michigan, we have those interprofessional communities, but it's often a challenge to connect them and to get the expertise in one domain working in the operations of another, especially at a big place that has a lot of internal complexity. And so I can well imagine how hard it is to change the big ships of a university like ours.
My anecdote because Mike did an anecdote, is I remember early on talking to a CEO of a major academic medical center who was really trying to do a big sustainable building project. And he was really hitting all kinds of turbulence, even in his own organization, about the prioritization of it, et cetera. And when I said to him, I guess you never really thought you'd be basically refereeing the reconvergence of allopathic medicine and public health, because that's what this all calls into question. And he laughed and said, you're absolutely right. In an academic place like ours, those are two radically different
conversations.
Conversations.
Yeah.
And it does cause these institutions to have the same sort of interprofessional and interdisciplinary stance that we just talked about earlier, right? For our own firms. It's happening everywhere.
Yeah. So speaking of those connections within firms, Mike, you've talked in Fast Company about projects that draw on innovation in office design or retail design to make better spaces and better use of space in healthcare settings. That seems like one of those connections across internal specializations within our practices. How have all of the debates about the future of the office and changes to retail that the pandemic has accelerated, how are you thinking about those convergences in our design skills and principles moving forward?
Yeah, that's a really good question. My answer is finally we have their attention. Healthcare has been one of the slowest industries to move anywhere, really, especially as it relates to workplace environments. And if you kind of look at the history of the healthcare workplace environment for the care providers, it hasn't changed much in decades. And you start looking at Uber and Google and places that are completely reinventing workplace and workplace strategies and work from home strategies and free officing and no assigned spaces and all of that. Healthcare has never given up real estate as a reward as their philosophy until now. And so we've been I personally have been trying to push this for a long time, that the vast majority of the space we have in our healthcare institutions goes wildly unutilized 90% of the time. It's just sitting empty. We give offices to faculty that literally are there for 10 minutes every other day, right? And the rest of the time they're sitting empty. And for the first time, I'm actually hearing a lot of interest in saying now we need to use the pandemic as a reason to start to rethink our space strategies, which is amazing because I've been trying to do it for 25 years. It took a pandemic, actually, you know, like now I think I've made more progress in the last 10 months than I have in 25 years. But the funny thing is it's hard to predict what the answer really is. I mean, you know, we've probably all by this point had some sort of virtual visit with a physician, and they're incredibly convenient. You can do it right in front of your computer. Don't need to leave anywhere. And so your first reaction is, well, I probably need less healthcare space because I'm going to be seeing more patients virtually. And the answer is maybe that's true. But I think even as we're trying to work with some of the top institutions in the country to try to figure out, like, what does virtual visits mean to healthcare space, to officing, to where that visit has to take place, you know, the provider actually has to be somewhere. And likely not in his living room or dining room, likely in some professional environment that actually takes space. And perhaps the provider is actually going to be using space without a physical person in it, more so in the future than they are today. So you actually might need more private, let's call it officing space. I'd like to think of it as studio space than you might have had in the past. So I think what it's doing for us is it's giving us a chance to, I think, like reinvent space utilization in a way that is going to be creative and take the place of, you know, this kind of physical and digital world that we're going to be moving into. And that's, I mean, that's one thing for the students that are out there. If there's any students in the audience, I think, you know, the designers of tomorrow in almost any typology, but in healthcare for sure, you know, they expertly need to be able to blend the physical and the digital environment. And those two things are going to happen separately. They're going to happen together, and they're going to change the way we think of how we use our buildings and how we use our space. So I'm actually excited that I think the pandemic is going to give us a reason to rethink and get rid of some of the old rules.
Yeah, I hear you on the question of officing, because we, you know, like many organizations, right, at Taubman College, we've had a lot of misfit between our supply of office space and the way people actually want to use it. And this, I also am hoping that we will learn as we fold back in more in-person activity, how to make better use of it. But when you talk about the studio, talking about a studio more than an office, do you mean in the sense that we're now, each of us has set up at our dining room table, you know, a little broadcast studio? Is that the sense in which you mean it, or are you imagining something different when you use that word?
Well, so I actually use the word studio for two different reasons, and I use it with my clients because they don't understand what a studio is. Architects do, right? We work in studios. We learn in studios. You know, we're educated in studios. Most people are not. And also, studio means exactly what you said, your little broadcast area with the amazing little gold background behind you. And I'm blending the two for a very specific reason. One is, you know, when you're in your studio, meaning I need to talk to a patient face to camera, you know, you need to be in a professional environment. You need to have great light, great sound. You know, there can't be misunderstandings. So you just need literally like a NBC studio environment to do that. That's appropriate. But you also, medicine is a team sport now. You know, no longer is it one physician that's providing care for everybody. You know, it's a navigator, it's a social worker, it's a dietitian. You know, it could be a financial counselor. There's all kinds of people that need to interact to improve health. And the studio, the architectural studio, is a place where people get together to work as a team. And that's exactly where medicine is moving to. So my studio analogy is actually both all at the same time.
Yeah, thank you. Parini, you spoke eloquently earlier about the importance of attending to the staff and the workers in healthcare settings and to their well-being, their satisfaction in their jobs, access to daylight and nice break spaces. And I know that mental health more broadly, or maybe more narrowly in a more specialized sense, is also a passion and priority of yours. How can design, whether it's in a healthcare setting or in other settings, best contribute to mental health?
That's a very good question. And as we've been discussing, the pandemic and the events of the last year have kind of made us rethink how we practice. Also has made us look at some of the inequities in our society with a lot more openness. And while as a nation we face a lot of challenges in healthcare, there's so much uncertainty, there's so much disparity. But I do think that through all of those unknowns, architecture can work to create a unified environment for a patient and for their family members. And in designing for mental health or behavioral health, that becomes even more important. Safety and dignity to the patients, to the family members are, I would say, the key focuses. Visiting a hospital for anybody, whether you're relatively healthy or not, can be, it is a very traumatic experience. You are under a lot of pressure, there's a lot of nerves, and so design is our way out of that. Clear wayfinding, a hierarchy in our spaces, material choices, privacy, lighting design, art, indoor, outdoor spaces, those can all help. So destigmatizing mental and behavioral health is also a very important factor. Integration of the community. I'm sure that was probably discussed at the advisory board, 5-person breakout session, but poverty, mental health, design, community, how those all come together, I think is going to be our focus as we work on these big campuses and healthcare facilities.
Your remarks, Parini, are connecting to a book that one of my colleagues at Taubman just published. Joy Knobloch published a book called The Architecture of Good Behavior this year that is in part a history of community mental health clinics. One component of the book looks at that shift, and Joy tracks some of the changing ways that people have attributed mental health impact to the built environment. And I love seeing you connect it to issues of equity and workforce, the benefit to the workforce in the sector, as well as to patients and their families.
Well, and I was thinking about a recent U.S. News and World Report webinar that I tuned into with children's hospital executives. And they were talking about the impact of telemedicine on behavioral health visits, and or some of the surprises that they've learned about, through the pandemic. And one of the surprises is how much better adolescents do with telemedicine behavioral health visits than going physically to the clinic, and how the providers are saying it's much better to see the child in their own environment, where background does matter, and you can, and even in surprising ways. They were talking about how no one thought physical therapy would really do well in telemedicine, but for the same reason, it's done quite well. That the therapist can look at the physical environment that the patient is in, and then figure out how to design the exercise program that they can execute in their own environment. And that they've
like through a video walkthrough or other tools like that.
Yeah, and so it's going to be interesting to see. In a way, it's like the cathartic moment of medicine saying, "Oh, there are things to learn about our patients from their home environments, and to bring our care to the home, even if it's virtual." That I think could have a pretty big impact on how people think of their real estate assets over time, as the technology continues to improve. And convenience continues to be really important to people when they seek their healthcare.
Well, I think one area that's going to be a massive intersection, just to combine Felini's and Robin's comment about pediatrics and behavioral health, that's an area that's just going to explode over the course of the next 10 years. I mean, the pandemic has forced, children in their most impressionable years to not interact with their peers, to, not go out of the house, to not be educated in a way that maybe, is incredibly viable. And you just imagine these 4, 5, 6, 7, 8-year-olds 5 years from now when they're entering their adolescent years and they missed a huge piece of their upbringing that's going to be so different than anybody else. So I think as we're looking at the future, especially at the future of behavioral health, we just see a mountain over the course of the next 5 years of adolescent children and adolescents that are going to have, mental challenges that we're all as a society going to have to overcome. It's just going to be massive.
Well, as you may be seeing in the comments, the question of telehealth really sparked some interest on the part of our audience, and so I appreciate that you have just sketched out some of the nuances of how that might play out on the patient end, not just in terms of the space allocations within a healthcare facility. There are two other questions in here that I see connected. Sophia Phillip asked about the most effective ways of inviting healthcare stakeholders to engage in the design process and how to sustain their empowerment. And then a little bit earlier, we got a question from Frank Jesse about how you convince hospital leadership to address environmental health issues, something that Robin, you touched on. So questions of how do you make the case, either to the hospital administrators for a more expansive view, or how do you hear from the people who are going to be working or seeking treatment and engage their insights in the design process?
Maybe I can jump in with a quick perspective, and it's a short one, but it's something that I found incredibly powerful as our role as designers. We spend a lot of our clients' money. We spend a lot in healthcare. We spend $3.6 trillion in North American healthcare a year. The irony is hospital construction is only 2% of that. It's a really small piece of total healthcare investment. But when you start talking to a client about spending $100 million, $500 million, $1 billion on a building, it gets their attention really quickly. And I've found like the power of the number allows you to migrate into conversations that you wouldn't believe you have the ability to migrate into. Because we'll ask our clients, how are we delivering healthcare in 30 years? Because that's what we need to think of as we're designing the building today. They don't get a chance as leaders to think 30 years in the future. Usually they're thinking about, what's my next meeting this afternoon and, what's going on next week. 30 years in the future is a time for them to actually stop and reflect about how are we living in a society, and is there a different way that they could even be thinking about spending their dollars as they imagine the future. And I'll give you an example right now. This week, I have a client that's building a big replacement hospital. We're debating whether to build a very large behavioral health unit inside of it. And we started asking the questions about how they're delivering behavioral services today. Who are the population they're delivering it to? Where does this population exist? And when we started probing into those questions, we really realized they don't really have a behavioral health strategy. And their strategy shouldn't be to build more beds and house more people in the hospital. Their strategy should actually be going into the communities and providing proactive support for mental health. And so they actually decided to turn down their investment in capital, take that same money and put it in preventative programs for mental health in the community. And in my mind, it's like, that's an amazing win. I think I just improved society and I didn't build a building.
Well, and I'll comment and say that that question about environmental health, how you address environmental health, nonprofit hospitals, right, have a positive obligation to provide community benefit in lieu of paying taxes, right? That's the contract they have with us as Americans, and typically what they have done is they've basically provided care to people who don't have insurance, and they've used that as a way to prove community benefit. And when the Affordable Care Act happened, and it looked like more people were going to be insured than ever were before, the question arose about what was going to happen with community benefit, because it has been challenged in Congress, the tax exempt status of hospitals, because So many for-profit hospitals actually deliver just as much uncompensated care as nonprofit hospitals, but they pay taxes and nonprofit hospitals don't. So one of the big moves has been to do environmental health work as community benefit. And the IRS recently, in the last 10 years, has opened up the definition of what qualifies as community benefit to allow some of those programs to get a foothold that way in the nonprofit hospital world. And I think everyone was poised after the Affordable Care Act came in to say, okay, is that really going to expand as there are fewer uninsured and hospitals aren't delivering uncompensated care at the level that they have been? I think the last 4 years sort of slowed that down, given the whole situation of challenging the Affordable Care Act and what was going to survive and all that. So we'll see if that continues to be the way that hospitals move into the prevention area more robustly.
Yep.
If they can squeeze it out that way.
And Parini, what are your thoughts about engaging those stakeholders you talked about earlier?
Well, in terms of engaging stakeholders for some of our design ideas and methodologies, it depends on the stakeholder. It depends on the client. We have some clients that are so focused on staff retention that they want to make sure that their interior environments are an appealing place for staff to want to come to work, that they can recruit and retain. There are other clients that we have from a sustainability point of view, recognize the monetary benefit of a net zero building in Southern California. And so that's really driving them in their focus. And so that conversation kind of becomes more about the payoff and the payback for what they're gaining from a building of that type. I would say as architects and designers, we need to have a position and we need to work within the constraints of our clients and stick to what our position is. And that is probably the biggest impact as designers and architects that we can have on the projects that we work on. You might not, have a LEED certified building because of the client's request, but what you specify, what you design can have that's a huge impact, and just tweaks to your materials that you use, your specifications, your testing. I would say that's all in our control and can all fit within our clients' budgets, where the stakeholders might be less opposed to that type of dialogue.
Really well said, Parini. I think that's true, that all the impacts are a choice. They're all a choice. So it's helping clients choose differently, right? That we have to be committed.
We've focused a fair, you've already surfaced in a few different ways, a few different ways that you see the pressure and the new perspectives of this pandemic year changing, especially healthcare facility design. In our panel on the future of the office a couple of months ago, there was lots of speculation about how office workers and people who come in for meetings might bring new expectations to bear on other kinds of workplace around health. What are your thoughts, or I hesitate to say predictions because if I have learned how hard it is to anticipate the future this year vividly, but what are you seeing or imagining across other practice sectors as we design for health in workplaces, in homes, elsewhere?
I can say flexibility, acuity, designing for more sick patients, being able to handle a pandemic or another event like this in the future is a conversation we are always having with our clients. Hand washing, but that's that is kind of a new focus, or a renewed focus, I should say. And my third one would be, aside from telemedicine, or maybe piggybacking onto telemedicine, home health, I think is going to be a big one that comes out of the pandemic. The nursing home and what was happening there with coronavirus was so tragic. And I think that loved ones are going to be staying at home when they're sick, and how our healthcare providers can engage with us while we're at home is going to, I think, be a big trend for the future.
You know, I'll say also that I think it's going to be important for us and for hospital owners to really see the intersectionality of a lot of these strategies, that in the face of a pandemic. And the example that comes to mind is that we've all been, everybody in this group, on this webinar, has been talking to clients for a long time about biophilic design and bringing nature into hospitals, and how we need more views and we need more daylight because it improves staff retention and it's better for human health. But what the pandemic taught us is that having outdoor spaces that staff can go to easily during their shift and pull off all their PPE and breathe is like huge. Like, for all the kind of softer benefit that we thought when we design in these outdoor spaces, to watch how they've been used during this pandemic sort of says, would you ever build one without this? Knowing that these people are working, as Bernie said, 12-hour shifts, wearing layers of protective gear that they are not allowed to remove inside the walls of the building, right? There's nowhere to go to take it off. And watching them go outside and pull it all off is like, you realize how important that is. And I think there's many other strategies that you can think about that that we've all been designing into buildings that have really paid back in this, even though we don't see them as pandemic strategies. And so I think it's, again, looking at all that intersectionality as we move forward.
Yeah, I would. There's a word that that's coming to me that I'm going to use to talk about the pandemic's impact on healthcare and other businesses, and that's resiliency. And that I measure that in all kinds of different ways. It's business resiliency, because funding has changed in all kinds of ways for a lot of people over the course of the last year. And our healthcare clients' funding changes. Really, it's a political cycle. Every president or two, there's different funding strategies, but our institutions need business resiliency. They need resiliency to deal with adverse effects. The pandemic is one adverse effect. I happen to be talking to you from the tundra of Houston today, because I came down here last week and I cannot get home because they had a whopping 1/4 inch of ice, and now everything is shut down. So, just weather resiliency, I think, is going to be important, because it's going to be thrown at our buildings in ways that we can't imagine. I heard a news report. They're trying to figure out how to keep the Texas Medical Center powered up, because the windmills went down in Texas and the grid is going down. And, that's something that I don't think anyone would have imagined a week ago. So, you almost can't predict the kind of adverse activities that are happening, but I think we need to do a much better job of thinking through it and modeling it than we ever have in the past, because when some mass event happens that takes down some key part of our system, we are so lean, we are so efficient, we've eliminated every bit of waste. And the second a blip happens, it just stops everything. And we can't be that dependent on everything running perfect anymore. So I really see
redundancy and resilience.
Yeah, exactly right.
Well, yeah. Thank you for your resilience in sticking with us despite the disruption to your travel plans. I'm glad you're able to join us.
I'm glad to have power. I didn't about 6 hours ago, so I thought I might be in trouble.
Yeah.
Power's back on here. Yeah.
I have one question, thinking about a thread that you've touched on in a couple different ways in the conversation. It's using outcome-based data and analysis and feeding it back into the planning and design process. So we know that, you know, evidence-based medicine and outcome-based perspectives play a bigger and bigger role in healthcare and health policy and healthcare design and delivery. And I think about the tech sector offices and companies like WeWork that Mike alluded to earlier are also using tech and data to recursively analyze their operations and change the way they design facilities or develop business products. Is that another area of convergence between healthcare design and other kinds of architecture, that we see health outcomes increasingly measured, monitored, and fed back into the process, whether it's office housing or a hospital or a school?
I mean, I do think that's a huge piece of our future healthcare model, and you know, previous funding models were really focused in on outcomes and funding hospitals based on more positive outcomes, and so people started really becoming outcome focused, which I think is a different kind of a question to be answered. So you know, you kind of raised two things. One is an outcomes based philosophy of what is the outcome I'm seeking, and then back that up into what is the answer that I need to design around, in the case of an architect. The other one is the use of data. And I don't think we've yet harnessed the kind of data that we have to better improve the environments that we create for people. I mean, there's so much data that just goes unused. And even the data that we do use, I don't think is always the most reliable or dependable. So if there is an area I'm hopeful that we can be much smarter about, is how do we actually use data in a way to positively influence what we're doing. I think it's a little sparse today, and I hope it's a lot more robust in the future.
I think the data collection, as you mentioned, we will continue to see how that influences the practice of medicine and the design of healthcare facilities. And I think that in terms of technology, artificial intelligence, when it comes to helping our physicians and our healthcare practitioners, as that becomes more, as we start to use AI more in their documentation, medical records, freeing them up hopefully to care more and have that human contact, we will start seeing data being able to be mined in more meaningful ways.
Yeah. I'm going to do a couple more, maybe just quick questions, and then shift to a final question about how we prepare the next generation. So Alina Osnaga in the comments has asked whether virtual reality might be one of those technologies coming into healthcare. And then on the other side, Wenyan Ji, who's also dialing in from Houston, notes that some people find tech inaccessible or baffling, and are there ways to actually reduce the amount of technological interface needed?
I think those are both great questions. I've been trying my last couple of projects to do extraordinarily tech-forward ambulatory solutions for my clients. Ones that really embrace, literally almost like a Southwest airport or Southwest airline mentality. You can like buy a ticket, get on a plane, get off a plane, and never interface with anybody if you choose, or you can interface with all kinds of people. So I think as we look at healthcare, we have to have both solutions. There's no question that there are people that embrace technology. There's people that don't embrace technology, and it's almost not necessarily an age thing necessarily as much of personality. And most healthcare institutions, we're dealing with people when they're in their most vulnerable position in life. So sometimes, that will make a techie actually want to talk to somebody too. So I think personally, choice is important as we start thinking about, putting technology, the burden of technology on our patients. I think it has to enhance their visit, not necessarily be the only avenue
the
for
only
their visit.
pathway. Sure.
Yeah.
Seamless visit would be being able to check in on your phone, or going to a kiosk when you arrive, or going to a receptionist and talking to a person, and having that freedom of choice would be pretty seamless.
I like the concreteness of that. So we're in our home stretch. We've got about 10 minutes left. And one thing I definitely want to be sure to ask you about is how we can best, as a school of architecture, urban design, urban planning, how can we best train future practitioners to connect their design capacities with these questions of health that you're addressing? So for instance, we have a Master of Science in Design and Health track here at Taubman College, small and just a few years old. And we're aiming to more deeply connect that to the interprofessional educational opportunities that a university like Michigan offers. But most of our students are in a Master of Architecture or a Master of Urban and Regional Planning. They're not doing a specialized degree. If they're interested, if they agree with you, as surely they do, that this is going to be one of the most salient dimensions of practice in the next decades, what should we prioritize in teaching them, and what should they prioritize in learning?
Well, I'll take the first pass at it. From my experience, the best learning comes from taking what you learn in school and taking it into practice. So I can't stress internship enough, and the variety of internships that I had when I was at Taubman. It was not just in healthcare. I worked in many different organizations, but it all kind of came to community benefit, and that's where I realized what I wanted to do. Finding a good mentor once you find that internship or that job is so key. Healthcare design is very technical. There's a lot of restrictions, codes, a lot of terminology. And so finding someone that will be able to guide you, help you, answer your questions, and someone that you agree with when it comes to your own design sensibilities and how you want to help the community, it's probably the best thing that you can find to help your career.
Yeah, maybe I'll weigh in, and I'm going to say something that might surprise my panelists. I'm not a big fan of universities having healthcare programs. And over the years, I've actually taught at many of them. I've been in studio at many of them. I've been a critique of many of them. So I've been involved in maybe a dozen. And I guess the reason I say that is that healthcare is extraordinarily technical, and there's an entire vocabulary you need to learn to even be a healthcare architect that is not a human vocabulary. I mean, I know more acronyms now than I could ever imagine. And I would also say that there's something I call the tyranny of expertise. The more expert you become at something, the harder actually it is to ideate and to create something new. I think as educators, I think you're really training people to think, and you're training people to create and solve problems. And healthcare is something that needs massive problem solving. And you don't necessarily have to be an expert in healthcare to solve problems. I think the funnest teams that I work on are the teams that have hardly anybody that has any healthcare experience trying to solve a problem, because they think of it in a completely different way, naive to the restrictions that sometimes were put on. And they actually come through with breakthrough innovations. So I think that creating problem solvers is number one. You have to think about a lot of things. You need to be insanely curious about everything to be an architect. Everything, just insanely curious. And cool assignments will come your way. We had a client that actually just gave us an assignment. The assignment was return joy to nursing. That was the assignment. And we put an entire team together to focus on that. It was one of the funnest things I've ever done. And, because they needed somebody that could just think and think in a very different way. And, they go to the outside industry to design creative consulting firms to think in a big way, whether it's an IDEO or somebody like that. They're coming to architects more often now than I ever imagined, with questions that don't really have a lot to do with built environment, because they've recognized that, we as a profession are amazing problem solvers. And we need to start thinking ourselves in that way, and not necessarily as deep subject matter experts in one particular building type.
Right, and I totally agree with you, Mike. I think it's the architect as facilitator. So I think, developing people's facilitation skills, their inherent curiosity, their strategic questioning skills, that surface all the sort of complexity of the problem is really what it's going to take to get at these wicked problems. Because some of these, like changing the US healthcare system, is a wicked problem. Like, it's not going to be solved by any one discipline looking at it, or solving the health, improving the health of the US population is an enormously complex undertaking. But I think architects are, I agree with Mike, we're good problem solvers and we're good facilitators. And that's the nature of our studio training, right? And I think it's why you're seeing, medical education and interprofessional medical education being transformed on a kind of studio model, that increasingly people are seeing that these interdisciplinary broader teams are what it takes to do it, to get new solutions.
Well, I think it's really intriguing, like MBA programs and Masters of Healthcare Administration programs are now required to have design thinking classes. And I think it's amazing. Actually, one of them asked me if I've ever had a design thinking class. I'm like, that's kind of my job. But, so I think it's amazing. They're realizing the power of ideation, the power of, failing quickly and trying over and over again, and just a different way of thinking about problem solving. And that's just natural to us. And I think we don't leverage that as much as we should.
Yeah, I have been amazed. I think all of us at Taubman College have been amazed at the success with which students and faculty migrated from the physical online modes of teaching, learning, and making and creating and collaborating. But boy, do we miss that studio space for all of those generative, inspiring, interactive reasons that you all are talking about, and that I think you're trying to bring in different ways to healthcare workers and patients as well. So one of the things I have loved tonight is I feel like our audience stepped up right away with questions and also with comments, some of them from people who clearly have a lot of experience as healthcare practitioners or designing for healthcare. So thank you, audience, for joining the conversation with good questions and comments. We didn't always acknowledge them, but I know our panelists and I read them and factored them into our thinking. And in particular, thank you, Robin, Parini, and Mike, for sharing your insights and your experience. This has been beautiful to hear from you all.
Thank you for having us.
Yeah, thank you.
The invitation.
Go Blue.
Awesome. Yes, go Blue. And Mike, I hope you get home from Houston easily.
I'm trying. Just got another canceled flight. Maybe tomorrow.
Oh, no. Good luck.